Professor Maciej Banach, President of the Polish Lipid Association. The guidelines of the European Society of European Atherosclerosis Society are the most important one, taking into account management of patients with lipid disorders. And these guidelines, just presented yesterday, were very much expected, because the last one in 2016 are very well used. However, due to the fact that many new studies and research was published since that time, in many issues, in many aspects, they were simply not up to date. So in the new guidelines, there are many very important issues. First of all, we have lower thresholds for the highest risk patients. 55 milligrams per deciliter is a very important step forward in order to have all our patients on the target of the LDL cholesterol. It is very important because in most of the European countries and worldwide, the main problem is associated to the fact that we do not have our patients on the target of our treatment, of the dyslipidemic treatment. And there are many situations when we have patients very close to the target, 77, 78, 80, and we do not nothing with those patients. And because those patients are not on the target, they are still on the risk of the atherosclerosis progression. So having patients at the threshold of 55, we are almost sure that most of our patients will be at the level below 70. And we know from the interventional trials, we know from the EAS trial, that there is no progression of the atherosclerosis, there is no progression, there is no increase of the atheroma volume when we have levels of LDL cholesterol below 70. I believe it is the most important improvement in these guidelines. What is the most important to emphasize more from the recent guidelines? I believe that recommendation of treatment. First of all, there is a strong recommendation in order to treat our high-risk patients with combination therapy with ezetimibe and with PCSK9 inhibitors in case we are not effective with statins. So there is no consideration, there is simply recommendation. It is the same for the highest risk patient after acute coronary syndrome. After 4-6 weeks, when we are not effective with the statin therapy, we should immediately include combination therapy with ezetimibe and or PCSK9 inhibitors. And it is the same for primary prevention of FH and very high risk. So it is very new and a very straightforward recommendation to treat those patients, those group of patients at the very high risk of cardiovascular events. What is more, we have a new treatment and new therapies. First of all, there is a strong recommendation to use statins, not consideration, a strong recommendation in patients with hypertriglyceridemia, and also recommendation to use isopentyl omega-3 acid in patients with triglycerides between 135 and 500 in those as an add-on therapy to statins. We have also some issues associated with diagnosis, because first of all, we have an addition of the CAC score in patients with the low to moderate risk, which is very important. What is more, it is a recommendation of application of apolipoprotein B, because you know that there was a large discussion whether there is an additional adding value to LDL cholesterol, non-HDL cholesterol. Now we have a very strong recommendation, especially in those patients with hypertriglyceridemia, with diabetes, with metabolic syndrome, or low levels of LDL cholesterol. There are obviously some unmet needs, there are obviously some issues which should be further covered. There are also some doubts I personally have to those recommendations. First of all, I expected that there will be new risk stratification of the highest risk patients. I expected that they will be selected a new group of the risk stratification, which will be called extremely high risk patients. And in those patients, I expected that there will be recommendation to even start therapy with the combination therapy. Based on the data from the trials with ezetimibe and PCSK9 inhibitors, we are ready to define those patients at extremely high risk. So it was my expectations, but I believe it might happen in the forthcoming recommendation on consensus papers, which will be published probably in next several months. What is more, I much prefer having thresholds, targets which are based on data. 55 milligrams per deciliter, it is not based on data, it is expert opinion. In fact, I expected to have a 50 milligrams per deciliter as a threshold because it is based on the Odyssey outcomes, because as you remember, the inclusion the criteria and the target in this trial, which was expected for patients treated with alirocumab, was between 25 and 50, and we have additional sub-analysis on this goal of LDL cholesterol treatment, as well as we have a data on 50 milligrams per deciliter from the Improve It trial. So I would prefer having goals based on data, not rather than expert opinion. It is the same with the something which is maybe less important, but important for the people, that physicians, GPs, that treating our patients. If we have in all the guidelines LDL cholesterol levels for moderate risk 115, please do not change on 116, because it is obviously a calculation from the millimoles per liter, but it might cause some mess. So I would prefer being at the same level of LDL cholesterol 115. But these are less important issues, and I believe they might be covered in next recommendations. So the selection of the extremely high-risk patients, target which is based on the data. These recommendations started completely new era of effective treatment according to the lower the better of LDL cholesterol, because we might predict that lowering the thresholds of LDL cholesterol, due to this fact we will have more and more patients being on the target. Having very strict recommendation how to treat patients, including very strong recommendation from combination therapy, and very important issue how to treat elderly patients, because for the first time there is a recommendation to use statins in primary prevention in patients below 75, and consideration to use statins in patients over 75. I believe we have all the tools in order to be effective in lipid lowering therapy, and now all the experts from all over the countries, all over the world and Europe must do our best. We need to do our best in order to educate our colleagues, to educate GPs, educate physicians, educate all the physicians that take care of patients with lipid disorders, in order to implement these guidelines into everyday clinical practice.